And now we have a few interesting case, and to start it, I would like to invite Dr. Leonor Sioko from the Philippine General Hospital, Manila, the vascular surgeon, to present the first case, interesting case, type I1 Endoleak.
Thank you. Good afternoon, everyone. I'd like to thank Medtronic and the organizing committee for giving us this opportunity to present. We're presenting a 66-year-old male who was diagnosed to have an infrarenal abdominal aortic aneurysm during routine medical checkup for a prolonged diarrhea. So it's a relatively sick patient with multiple comorbidities. He's diabetic, he's hypertensive, has a 44-pack-year smoking history and continues to smoke. We did this case in 2022, and a year before that, the patient had a mild stroke with no residual, and he also has chronic renal insufficiency with increasing creatinine. So on CT, what is significant is there's a 5.8 centimeter infrarenal abdominal aortic aneurysm. The neck length is more or less around 10 millimeter, which is really the issue with regards to this case. Angulation is around 43 degrees. So we went about with what to do with this particular patient. Obviously, because of the short neck, open repair was an option. However, this patient really didn't want an open repair as much as possible. So we looked into other options, which would include chimney EVAR, as well as EVAR with endo-anchor. One of the limitations we have in the Philippines is that we don't have easy access to a covered stent. This was in 2022. I don't know with other countries, but this was a time when we did have a lot of logistics problems with a number of medical supplies, even including dialysis catheters at that time. So we were having problems with supply. So we really didn't have much option except for EVAR with possible endo-anchor. In the evaluation of the patient, however, we noted that he had severe coronary artery disease, such that he had to undergo coronary artery bypass graft surgery prior to the procedure. The CABG went very well, however, and he was discharged after 3 weeks, after which patient was then readmitted for definitive surgery. So at this time, having undergone open heart surgery, he was really adamant and not to have any open surgery at all. So we then proceeded to do EVAR. As you can see, the neck is short, less than 15 millimeter, but slightly over 10. Post-deployment, there was a type 1 endoleak. So although if you can look at the proximal extent of the graft, they're 1 to 2 millimeter below the lowest renal. At that, we balloon it, and it's still the type 1 endoleak was persistently there. At this point, we thought that if putting in a cuff wouldn't really help, so we proceeded to put an endo-anchor. And fortunately, post endo-anchor, the type 1 endoleak disappeared. So this patient was sent home after 3 days. The patient followed up after a month with a CT. Unfortunately, again, we saw a huge endoleak. And on CT, the endoleak was noted to be most likely type 1. So at this point, we went about with the discussion as to what to do. And again, we had two options, which was putting in a chimney or do an EVAR with more endo-anchor. At this time, the forward graft was still not available. So we really relegated to putting more endo-anchor, and hopefully, this would solve the problem. So here, there's the endoleak coming up, right there. There. So as mentioned, we opted to do application of 2 layers of endo-anchor. Unfortunately, I don't have the video of the procedure itself. Suffice it to say that we were able to treat the problem. We had to put more or less 20 endo anchors on this patient. And at that point, we were even told that we held the Medtronic record for the most endo anchor in one patient. Nonetheless, we were able to treat the problem. And on follow-up, after slightly over a month, there was no endoleak. No. Apologies for, I don't know why this is so slow.
What do you mean double layers or two layers of the endoangle? How far apart of these two rows?
Just slightly under the first one.
Right after?
Yeah.
Okay. And you do the same recommendation of 60 degrees or 45 degrees and you go maybe 6 or 8 of them?
Yes. So anyway, suffice it to say that there was no endoleak on this particular CT. No? But one of the things which we noted, no, and which was a little bit scary, is that if you look at the aneurysm sac size, no, this actually doubled, no, from pre-operative size. No? So if you remember correctly, the pre-operative size of the aneurysm was 5.8. No? On this particular CT, no, it's now almost doubled. So on coronal, as you can see, and on sagittal view. So at this point, there's really a dilemma. No? And I would like, if okay with the moderator, if I would like to ask the panelists, no, what they would recommend at this point. Remember that there's no endoleak, no? But you have a scary double-sized aneurysm sac. No?
Yes, please.
Okay, I think look at back at the initial CT. You are treating not just only the short neck, you have a diseased neck also. Mm-hmm. And look at the aorta upstream to the thoracic aorta. You have a lot of thrombus, a lot of like shaky aortas, irregularity, so that you treat the diseased aorta, the whole things. If getting back to the first operation, I used to consult this some kind of case to my CVT colleagues. They can do the CABG with simultaneously with the open repair at the beginning. If you are thinking that the patient quite high risk for the open surgery at that point because the point of unfit for the patient is coronary. But looking at the follow-up already and you fix the proximal already, I think I probably go to the detail or selective angiography first to make sure that you don't have a major endoleaks before you make a further decision, to do some things. But if you don't see any endoleaks and the sac is quite big, I probably go with the open surgery conversion to
So at this
fix.
point, you would recommend open?
So with that, Dr. Gizak, you bring the patient to the angio, put the pigtail right at the proximal ceiling zone, do the angiogram there. Maybe multiple views, maybe at least 2 views to see there is really no endoleak.
But actually, I think this time, I think with our IR colleagues, they can do the intra-op CT with atrial contrast injection.
Okay.
That can have more information regarding the minute or slow flow endoleaks.
Right.
And you can delay to see what happens at the next, I think.
Right. Let's say that we don't have the big machine and do the the higher resolution image, but we have to rule out proximal endoleak. And AP view only will not rule out proximal endoleak. CT scan is not complete evaluation. It's injection to the vein. Look at the artery. So maybe we don't detect that. I think, I don't know, Dr. Masada, we do the different ways? You do?
No, similar answer. Yeah.
Yeah,
But
proximal.
maybe open surgery is the first choice to do, I think. But relining, as I told in the previous talk, relining might be
You do open?
first.
What about the wrapping? We heard about the wrapping early today. Let's say that we open the patient, a high risk patient, just post cabbage may be okay for do the big operation. Let's say the high risk patient, if we cross clamp aorta, we may have cause some problem with the patient. Do you consider wrapping or you still?
I'm not sure because looking back at the last CT, look like the neck is not the real neck. is extend a bit higher than the expected neck. I'm not sure what happens later after the two sessions of the anchors or something like that. So have to define a little bit clearer, and also maybe look at the delay scan to see what is the exact extent of proximal neck of the aneurysms.
Well, during the re-intervention, we actually look at it at different oblique images just to really be sure that we're not, we were looking at or can see the posterior part. No? And on CT, we also look at it very carefully. And true enough, no, there was no endoleak. No? So anyway,
Also, but if you look at the scan, actually endoleaks happen at the posterior aspect of the graft, and that the difficult part. I think you didn't put the anchor at that point. That's right.
Just trying to join the discussion. Before you review, what did you do? I think if we don't see any endoleak, proximal endoleak, this aneurysm is enlarged too quick to do nothing.
Which is really scary, yeah.
Yeah, I think we have to do something about this patient. And so even though there is no any proximal endoleak, I think we need to convert. To convert and do anything depends. But I think we would do I would think I would do the same as Dr. Masuda showed, that remove the graft and put the surgical graft. We don't need to take the whole thing out, leave some portion. At least there will be something in my mind doing that. I don't know what will happen. Dr. Masuda, Dr. Kedesak, you agree with that? Dr. Kwang, you agree with that, doing that?
Yeah, I think the suck is elapsed too fast. So we need to do something and totally agree with Dr. Bumfasit. Yeah, so please go ahead in interest of time.
Well, we actually opted to observe, no? And the reason why we decided to do that is that you have remember that when we diagnosed the endoleak by CT, and the time between the diagnosis by CT and intervention, we didn't do anything. We got the CT right after intervention. So we thought that it's possible that the acute dilatation happened before we did the re-intervention. So we thought, let's give it a month. And true enough, fortunately for us, after a month CT, there was sac shrinkage. And the sac shrinkage persisted at 1 year. So from 11 something, it became 9, became 5.7. And actually this patient was admitted last week for melena. The gastroenterologist wanted a CT, a plain contrast CT. And this revealed further sac regression. So I guess lucky for me. So this is just to look at, put into perspective, the sac regression over time. Here. So just a little bit of a discussion. I still have 2 minutes. The anchor registry was mentioned quite a lot today. And the authors actually came up with a study, and this was published 3-4 years ago, looking at the cohort, a short neck cohort. And as you can see here, there's 70 patients in this particular cohort with an average neck length of 6.9. And in this particular study, they noted that out of the 70, only 4 patients had a type 1 endoleak at 30 days, for which 3 of them resolved spontaneously by 12 months. And although it was really scary that there was a sudden dilatation of the sac, after the second intervention with putting a lot of endo anchors, it also regressed quite rapidly. And I was wondering what would have caused that. So does the endo anchor really lead to sac regression? And if you look at the Peru registry, they sort of analyzed the sac evolution patterns in patients with hostile neck, comparing standard EVAR and those who underwent ESAR, with inclusion criteria being there was no proximal adjunct aside from the endo anchor, the neck length has to be less than 15, and they have to have a minimum 12 months follow-up imaging. They noted that there were significantly more patients who achieved sac regression in those who underwent ESAR compared to the ones who underwent EVAR. And at the same time, the significantly higher cumulative sac regression in those who underwent ESAR, with no difference in type 1 endoleak and mortality. So, lessons learned, if possible, let's stick to IFU. But we know very well that there are really some patients who are unsuitable for open surgery. And in that regard, we're quite fortunate to have a lot of options, be it different types of graft, like a conformable gore, or for anaconda for those with tortoise anatomy. Unfortunately, we don't have that in our country. We do have adjuncts as well. That would include the endo anchor, maybe in the near future, we can do chi-EVAR if the stent graft is available. Nonetheless, this particular case have shown us that endosuture aneurysm repair, though indeed is a viable off-the-shelf treatment option for short neck AAA patients. Thank you.